Hello, my name is Sarah Sargalski, and I'm a graduate nursing student at the University of Texas at Arlington. And today I will be performing a cardiac assessment. Knock, knock.
Come in.
Good afternoon. My name is Sarah. I'll be the nurse taking care of you today.
Thank you. Good to meet you.
Good to meet you too. What brings you in to see us today?
Well, I've been having some sharp chest pains when I take deep breaths, but other than that, I feel okay.
Okay, let's talk a little bit about the chest pain you've been experiencing. Can you tell me when you first noticed it?
I guess it's been a few months, but lately it's been more frequent.
Can you show me exactly where you feel the pain?
Yeah, it's sort of on the side of my chest here.
Okay. And does the pain come and go, or is it constant?
Yes, it comes and goes, but it seems to get worse when I lift heavy things.
Okay. How would you describe the pain?
It's like a sharp twinge, sort of like a twisting kind of feeling that sometimes takes my breath away.
Okay. And you said heavy lifting makes it worse. Does anything else contribute to the pain?
Not that I can think of.
Does anything help alleviate the pain or make it better?
Well, certainly not lifting those heavy objects.
That makes sense. Does the pain occur at a certain time of the day?
No, typically when I'm, lifting or moving things around, but now that you mention it, when I get close to bedtime, I can feel that pain.
Okay. On a scale of 1 to 10, 10 being the worst pain you've ever felt in your life, think childbirth. What would you rate this pain today?
Well, I don't really know what childbirth is like, but I'd have to say this pain is around an 8.
Okay, that's pretty significant. Did you ever experience any palpitations with your chest pain, like a thumping in your chest, feel your heart racing?
No thumping or racing.
Okay. And how many pillows do you sleep with at night?
Well, that's a pretty silly question, but I only use one.
Well, that's a good answer, because sleeping with 3 or 4 pillows usually indicates a cardiac problem. Have you noticed any swelling in your legs?
No, not that I can think of.
Okay. And have you been too tired lately to perform like your activities of daily living, such as like brushing your teeth, brushing your hair?
Well, come to think of it, I don't really like to do the laundry, but I'm certainly not too tired to do it.
Okay. Let's talk a little bit about your history. How would you describe your overall general health?
I would say overall, I'm pretty healthy. I eat a healthy diet and I try to exercise regularly. However, I haven't seen a doctor in quite some time, probably a few years now.
Okay. Well, you're taking steps in the right direction today. Are you taking any prescription medications?
No, I'm not on any prescription medication.
Okay. Have you ever had any hospitalizations, illnesses, or any blood transfusions?
No, none of those.
And how about your immunizations? Are they up to date?
Gosh, I'm not sure, but I did get a flu shot this past season.
Okay. And any medications that you're aware that you're allergic to?
No allergies.
Let's talk a little bit about your family history. Does anything run in your family? High blood pressure or diabetes?
Well, I'm actually adopted, so I don't really know any of my family history.
Okay, that makes it simple for me. What do you like to do in your spare time?
Well, I like to go to the movies, hang out with friends. I try to play golf as much as I can and be outdoors.
Okay. When you go out with your friends, how much do you drink?
I have a couple of beers, but I try to stay home if I have any more than that.
Okay. It's definitely smart. Do you smoke any cigarettes or use any illegal drugs?
No, I don't smoke cigarettes. I think they're gross, and I don't do any drugs.
Okay. How would you describe your mental health over the past few weeks?
Well, I wouldn't say I'm having any crazy thoughts or voices in my head, if that's what you mean, but I have been pretty stressed out at work now that you mention it, but not enough to get in the way of my personal life.
Okay. What do you do for work?
Well, I'm in the medical field. It's a lot of paperwork, so it can get monotonous, but not too much heavy lifting until recently, actually. We've been moving out of our old office into a new one, so I have been lifting a bunch of boxes lately.
Okay. A brief personal history of Steve. Steve is a 30-year-old single male who currently works in the healthcare industry. He lives alone in an apartment where he reports that he is a little stressed out by work, but otherwise content with things. His last physical exam was over 5 years ago. He is seeking care today for his chest pain that has been ongoing for a few months. We will now perform a cardiac assessment on Steve. I've just washed my hands and we're going to go ahead and start our assessment here on Steve. So first we're going to begin with inspection. We're going to go ahead and look at his chest, look for any cyanosis or blue color. We're also going to take the time to look at his neck, look for any venous distension, and I don't see any venous distension on Steve. Steve also has a really good pink color. At this time we're also going to check his cap refill by pinching on his nail bed. He should have he does have a good less than 3 second cap refill, indicating adequate perfusion there. And we'd also like to take the time to inspect all areas of his chest wall. Just looking at all areas. Wow, that is quite a scar you have there.
Oh yeah, that's probably something I should have brought up earlier. When I was in high school, I actually had a spontaneous pneumothorax. It was so bad I had to have surgery where they reattached my lung to the chest wall. So, should have brought that one up, I suppose.
Yeah, definitely mention that the next time. Alright, we're going to go ahead and move on to palpation. I'm going to lower Steve flat into the supine position. Most importantly, when you palpate somebody's chest, you want to warm up your hands. Is that a okay temperature for you?
Yeah,
Not too cold?
Not too cold.
Okay, so proper palpation includes moving from the apex to the left sternal border to the base. And the point at which the apical impulse is most readily seen or felt is described as the point of maximal impulse, or PMI, and it's typically palpable within a small diameter. Large impulse is characterized as a lift or a heave, so no lifts or heave for Steve's today. While palpating over the base of the heart, I'm also going to feel for a thrill or a vibration, which I don't feel. And you'll also want to take the time to palpate the carotid artery at the same time. It should be synchronous with the cardiac rhythm, cardiac cycle. And you'll also want to palpate all the peripheral pulses. Steve's got good, strong peripheral pulses. I'm going to assess his feet down here. He's got a heart rate of about 80, and his heartbeat is regular. I don't feel any irregularities with palpation. I can also take the time to analyze his rhythm by connecting him to a cardiac monitor, but we're not going to do that today. So we're going to move on to percussion, and percussion is of limited value for defining the borders of the heart, and so therefore a chest x-ray, chest radiograph should be performed. But if a chest radiograph isn't available or isn't able to be obtained, you should resort to palpation of the cardiac border. So you would just kind of start from the anterior axillary line and move medially along intercostal spaces towards the sternal border. There should be a shift from a resonant sound to a more dull sound that'll define the borders of the heart. For auscultation, we're going to go ahead and ensure a quiet environment, which we have today. We're also going to make sure to warm up our stethoscope, because that can be uncomfortable for patients sometimes. So we're going to listen for the S1 and S2 heart sounds. S1 is auscultated as the lub sound at the beginning of systole, and S2 is auscultated as the dub sound at the beginning of diastole. So we'll start at the right second intercostal space, and this is listening over the aortic valve area. And then we'll move to the second left intercostal space, listening over the pulmonic valve area. And we'll continue down to the third intercostal space, and then to the fourth intercostal space, and this is listening over the tricuspid area. And you're going to end at the fifth intercostal space over the mitral valve area. Some of the abnormal sounds you'll want to auscultate for, and I didn't hear any of these sounds auscultating Steve, but sometimes you'll hear something called splitting, which occurs when two valves, either the mitral valve and the tricuspid, or the pulmonic and the aortic valves, they don't close simultaneously. So there is a normal physiological splitting with inspiration. And additional abnormal heart sounds would be your gallops, which are known as like the S3 and S4 sounds that are sound like the pronunciation of Kentucky or Tennessee. They're typically best auscultated with the patient in a recumbent side position. You can also auscultate for any snaps or clicks, which occur with valvular stenosis or mitral valve prolapse. You can also auscultate for any rubs, which occur when there's inflammation in the pericardial sac. It kind of sounds like machine-like, like whoosh, whoosh. And then there's also, you can auscultate for murmurs, which are caused by disruption of the flow of blood during the cardiac cycle. They can be described by harsh, they can be described as musical. Some people say you can describe them however you want to describe them. So this ends our cardiac assessment with Steve. Thank you, Steve, for allowing me to obtain all the information on you. I'm convinced that because of your history and your physical today, that it sounds like as though the chest pain you've been experiencing is not likely to be related to your heart. However, I would like to run a few tests with you before you leave today, if that's all right with you.
Okay, that sounds good. No problem.
All right, thank you.
Thank you.